So today I'm co-moderated by a couple of colleagues, and I welcome Helena de Grote. She's a former colleague of me who recently moved to the University Hospital in Brussels, and her focus is hepatopancreaticobiliary disease. She performs diagnostic and interventional EUS and ERCP. We welcome Dr. Stefano Francesco Crino. Thank you for being here. He works at the digestive endoscopy unit of the University Hospital in Verona. And his focus is also diagnostic, interventional EUS and ERCP. We have Professor Mariana Arvanitaki. She is from the Department of Gastroenterology and the Hôpital Erasme in Brussels, and she specializes in pancreatic disease, nutrition, and also endoscopy. Dr. Susanne Ribeiro, next to Mariana, is one of my colleagues. She's digestive oncologist with a specific expertise in pancreaticobiliary malignancy, and she also performs diagnostic EUS at our unit. And we are very happy to have Professor Julio Iglesias Garcia here in Ghent. He is the head of the endoscopy unit at the University Hospital of Santiago de Compostela. He is also one of the presidents of Euro EUS, and Professor Julio Iglesias Garcia has published a lot of articles in international journals and a lot of chapters in books, both national and international books. And he is known for his expertise in the field of endoscopy and especially in the field of endoscopic ultrasound.
Well, thank you, Peter, for your nice words. And it's a big pleasure for me to be here in this very nice event, and also sharing this table with these very good friends that I have here in Ghent, because it's my first time in Belgium. I've been traveling all over the world, but never been in Belgium before. So thank you for the kind invitation. And I will try to focus the talk of this morning, before we go to the case, on the past, present, and future of EUS advanced imaging. So if I can have the presentation, please. And this is a very important topic, because EUS is an old technique. I will show you some funny history on where we're coming from, because if you don't know, EUS started in the 80s. I think the first ever publication became from CBAC in 1986. And in fact, I can tell you that when I started with my trainee in EUS, that it was in the past 2002 with Mark Giovannini. I was trained, my mentor is Mark Giovannini. I thought that we were doing EUS to study the subepithelial lesions. And then I realized when I started to work in EUS that EUS really started in the world of pancreatic diseases, because we have all of the problems to check the pancreas by that time with the not advanced CT scans or MRIs that we have today. And whenever you want to do an evaluation of the pancreas by transabdominal ultrasound, it was almost impossible. We all know the report from the radiologists or from the gastroenterologists many times that pancreas was not evaluable because of the interposition of gas. And that was the position that EUS started to be developed. And it was really not to evaluate subepithelial lesions, that was my belief in the beginning, but it was really for the evaluation of pancreatic diseases. So if I would just ask for the...
Can we have presentation? Is not the presentation?
No.
Presentation from Professor.
But by just starting, I remember very nice the very first slide, because if we talk about the beginnings and to let you know how old I'm starting to be, it's very funny that in 1986, it was the time that Tom Cruise did the first Top Gun movie. Now we have just in 2022 the Top Gun Maverick, so it's the next session of, so these 20 years, we can see the evolution of Tom Cruise. At the same time, we can see the evolution of EUS. That is the presentation. Okay, that's it. So I don't know if I can move the slides. Oh, yes. So my lecture objective, just coming to the point, is try to know where EUS is coming from. I just start to talk a little bit about this topic, a little bit funny, but I think it's very important so you keep in mind where we're coming from. What are some of the concepts of B-mode imaging? That is extremely important. How we have evolved to advanced imaging. And the other point that you asked me is what to expect to the future. So I will just try to make a mix along the presentation, combining mostly present and future, and have just a slight images on where are we coming from the past. So as I commented before, the 1986 is the beginning of endoscopic ultrasound. That is the pictures of Tom Cruise when he was 23. And now that he's in the late 50s, coming to the 60s. So I think EUS has evolved better than Tom Cruise, although he has evolved quite well, I need to say. And the other idea is, remember that Out of Africa was the film that took the Oscar as the best movie when EUS started. And just have an imagine, because I've just been in front of the stadium for the Ghent, so you all know I am a big football fan, from Real Madrid, of course, the best team in the world. But believe me that in 1986, when we started, and that's just to have the concept of the evolution, the goal from Maradona in the World Cup will never happen today because of the VAR. So just think on the evolution, on the technology, that is the same evolution that we have in the technology for endoscopic ultrasound. And there is a continuous actualization and technical innovations. In fact, if we go to the evolution, I've just brought here the pictures of almost all of the scopes from the very beginning to today. And if you just take a look at the tip of the scope, there has been a great evolution trying to make the scopes a little bit more soft in the tip with a better quality in the ultrasound part, because at the end, we're talking about ultrasound, not really talking about endoscopy. We're talking about ultrasound. And I also brought here, just to let you know, all of the evolution on the ultrasound systems that we're using. Of course, this all you are looking is almost Hitachi Aloka, because from the very beginning, the two companies on ultrasound that have developed together with the echoendoscopes being mostly related to Aloka and Hitachi. And you have to the left part of the picture, the old ones, and to the right, the latest versions of the ultrasound. And at the end, the evolution of ultrasound is because of the combination of the increase in the knowledge on ultrasound together with the innovation in the endoscopes. So I want to summarize a little bit what is each of these techniques and what is the impact of these techniques in the evaluation of our patients. So I think you're all aware of elasto. We have two ways of elastography today. One is the strain elasto that is going to evaluate the relative stiffness of tissue by its response to compression. You know that we have two possibilities to do it qualitative, just to evaluate the color pattern. But now we have the option to quantify, and two options to quantify. We can do the strain radio and the strain histogram. Just give me a couple of very simple ideas, because I know there is a lot of controversy on elasto, and it's all a matter of understanding and learning, like everything in life. If you put me today, I'm a big fan of Formula One, and we have a big fight with Belgium, because of course I'm a Fernando Alonso fan. But if you put the best car with the best guy, you will have success. But it's something very important. You need to train. And training is key in life. It's key to understand EUS, but it's also key to understand that when you press a button, it's not only taking the images, but it's understanding how to do it and how to interpret the images. And for instance, we tend always to compress and tip up when you do elasto, and it's not the way to do it. You just need to get attached very slowly, because you are obtaining the compression with the aorta in the abdomen. So that's, for instance, one example on how you need to learn to understand. What we've learned is that hard tissues tend to be blue and soft tend to be red. And importantly, tumors, malignant tumors, because they have a high density of cells, tend to be hard. That's the idea on why we see tumors hard, because there is a high density of cells, high Ki67. That means a lot of cells, difficult to compress, whereas benign conditions have not so much cells and they are easy to compress. Then we have shear wave elasto. You all know about shear wave because we're coming from the liver. So this is the fibroscan. I'm working with shear wave for 3 years now. I still trying to understand how to do it in the proper way, because we have a problem with shear wave. When you do fibroscan, what do you do to your patient? You ask, hold the breath. I will ask my colleagues here how we can make our patients hold the breath while we're doing an EUS to have the best compression for shear wave. So I think we're working on it. I will send you some very scanned data, but we still need to learn how to do this better, because I think it can be very useful, but we need to understand how to do it to obtain the best information. We have the contrast enhancement, of course. What we're using in Europe is Sonoview. You know, there's some other contrast agents coming from Japan, which is the Sonazoid. And contrast enhancement, again, what we are going to evaluate is the microvascularization of whatever we want to evaluate. You know, there is two phases, mostly to the pancreas, the venous phase and the arterial phase and the venous phase. We do not have portal phase in the pancreas, so that's why contrast takes 1 minute when you do it for the pancreas. And now it is even better because we added the e-focusing and the curving imaging that is going to stabilize the image, is going to optimize all of the artifacts that we can obtain with B mode and the e-flow. So this is the combination with contrast, with the new concept of e-focusing that is really providing the best non-artifacts when we're doing the contrast enhanced evaluation. And the latest technique is detective flow imaging. And this is an amazing technique because this is based on B mode with the system, with the softwares and with the processors. You are able to get out of the B mode image all that is not movable. So you are only going to obtain the images of moving things inside of the screen. And what is the only thing that moves in the screen? Vessels. So DFI, based on the extraction of a stable image, is going to give us the information regarding microvascularization of whatever we want to evaluate. This is very new. There is very scant data, and I will show you some of my crazy ideas that I'm working in Santiago together with the team, together with Enrique, trying to obtain more information from this technique, compare with contrast enhancement, but also not comparing with contrast enhancement. And what is really the information that we are obtaining with these techniques? Look, EUS guided advanced imaging, we know that we've used it for years in solid pancreatic tumors, and I just tried to summarize in this table what are we obtaining. Look, we have role in solid pancreatic tumors for differential diagnosis, in which I show you here, there's a very sensitive, it's very easy to detect malignancy, and we need to learn to improve specificity, and I will show you an example on why and how to do it. But we also have a big role in staging. With some papers in elastography that improves the B mode, but also improves the CT scan in terms of vascular involvement whenever you're evaluating a pancreatic adenocarcinoma. So sensitivity is around 85 to 90% with very high specificities. And when you combine elastography with contrast enhancement, your accuracy to detect malignancy in your tumor can be as high as 95% of sensitivity, 98% of specificity. Is this precluding from making a biopsy? Probably not in malignant lesions, but probably yes, if you have a combination of image leading to a high probability of a benign lesion, for instance, when you're managing patients with chronic pancreatitis. So the best is to have some examples, and I want you to bring here what are the keys. And the keys, and I think you have the screen, this is two tumors that very much look the same, but, or here, they very much look the same, but at the end you see a green tumor and another blue tumor. So blue, remember, is hard, green is soft, and this makes us very nice to differentiate, for instance, from a pancreatic adenocarcinoma or a neuroendocrine benign tumor, G1, and it was G1 and it was green because low Ki67, low mitosis, low number of cells. And then we have the key in chronic pancreatitis. We always talk about the decreased specificity with the last two in chronic pancreatitis, mostly in calcific. Logical. What thing is harder than calcifications? Nothing. What is going to be the colors of calcifications? Blue. That means malignant. No, it means that it's very hard because it's calcification. So at the end, you need to understand and make a proper interpretation. So I brought this very nice case in this part of the slide because this is calcifications, of course, blue, but we have a blue spot here with no calcifications, and we target here. And this was a 9 millimeter foci of pancreatic cancer in the setting of a chronic pancreatitis. So interpretation, learning, and gives you a lot of information optimizing the management of your patient. So use it, but probably you need to learn. Of course, I invite you to come to Santiago if you want me to teach you. But there is a lot of people now, with a lot of capabilities in understanding and learning. And if you learn, it can be really, believe me, very, very useful in the management of these tumors. Something similar with contrast and enhanced harmonic EUS, and I just brought here some examples on how we can differentiate an hypovascular pancreatic cancer from an hypervascular neuroendocrine tumor, on a hypervascular metastasis from a renal cancer, or how we can see, this is an image from Paolo Arcidiacono, an image of an autoimmune pancreatitis. So this idea that we obtain with contrast enhancement really provides a lot of information on what is going to be the most probable diagnosis. So if we combine, as shown you before, as commented, we are going to increase our capabilities, moving to benign or to a malignant condition. So the combination of both is quite nice, believe me. And now we have DFI. So we've just presented, and we are going to present in UEG. So this is in premiere because it's going to be presented officially in a couple of weeks in Copenhagen. But we've just combined and tried to see if what we obtain with contrast enhancement is similar or not to what we obtain with DFI. And we're amazed that in 97% of our cases, and it's a series of close to 60 patients, we get almost the same information. That when advanced with DFI, we don't need contrast. It's a software that works without the need of injecting contrast. So this is something that we will need to work together to obtain information in multi-center studies and multi-center trials. But it's not only solid tumors, also cystic tumors, and we know that contrast enhanced is extremely useful. We will take a look now in the case on the evaluation to differentiate between mucin plaques and mural nodules, also for the characterization of cystic wall. And here you can see very nicely the uptake on a huge nodule inside of a cystic lesion that we already know in B mode, but it just reinforce what you see in B mode, or how you can see an enlarged wall you see here in the border, an enlarged wall that was not really seen in a normal case. So whenever you try to manage a cystic lesion, you have doubts in mural nodules, please use contrast enhancement. We still have no data on DFI in this setting, but please, if you have contrast by your side, use it because it's going to increase your diagnostic capabilities and you may preclude of doing biopsies that are probably not indicated. But it's not only solid lesions, it's also in diffuse disease. You know that I've been working a lot in the role of elasto in chronic pancreatitis, and it's really, really useful to try to establish the diagnosis mostly in ductal cases. I think it's not indicated for a calcific chronic pancreatitis. We know it's a chronic pancreatitis. But in this indeterminate or suggestive, according to Rosemond, I think elasto, it's an add value to be able to establish the real diagnosis of the disease. We've also detected a correlation between the radio and the presence of exocrine pancreatic insufficiency. And in this setting, we're also evaluating shear wave elastography. I told you that have been presented in the EPC. This is very recent data. And we saw that there is different values in the mean wave velocity and in the pressure according to the different stations of Rosemond classification, but we also find a nice correlation with the strain radio of the strain estrome. So probably we need to work. Maybe we are getting in the way to get good information by using it in the proper way. But another pancreatic indication is chronic pancreatitis. And this is a crazy idea that I want to show you while we're presenting in EPC, because we know that inflammation is related to microvascularization, to the development of neovascularization. And a crazy concept discussing with Enrique and with the pathologists at the unit is maybe if we're able to detect different patterns of microvascularization in suspected chronic pancreatitis, it can help us to guide if there is inflammation or not in the pancreas, because elasto detects fibrosis, not inflammation. So this is an ongoing study. I've crazily decided to make 4 degrees of uptake. I think this is in the very beginning. It's just to show you that we can obtain a lot of information and we need to keep investigating and keep doing research. Research is key in medicine, and I encourage all of the people that are attending to do a lot of research with everything that they're doing almost every single day. But just very briefly, because I'm going, I think I need to go to make the endoscopy, just that the world is not only the pancreas. Well, I mean, I love pancreas. My consultation is with pancreatic patients, but elasto also very useful for the evaluation of lymph nodes. And we are managing these patients with enlarged lymph nodes almost every single day. And it can guide you to differentiate between benign nodes from malignant nodes. Also for the evaluation of subepithelial lesions. And we know that these tend to be harder than leiomyomas, for instance. And the contrast enhancement pattern can also guide to a benign lesion, whereas as compared to a malignant lesion, depending if we have foci of non-uptake that are usually related to necrotic areas, more much linked to malignant potential of these lesions. We're using it for the staging of gastrointestinal tumors. We can here see the borders between the lesion and the layers. And in the other pictures, you can see that there is a growing of the blue pattern out of the layers. So that the first one, it was related to a T2, T3, non-T4, and this was clearly a T4 lesion. So it's also help if you have any complications in the interpretation of the B mode. We're also moving to do the EUS-guided shear wave for the liver. So it's not only that we are doing EUS-guided liver biopsy, not only that we are measuring the portal pressure, but we can also do an EUS-guided shear wave of the liver, not only from one side of the liver, but from left liver lobe, but also from right liver lobe. So maybe we can have also a role. And at the end, with all of this advanced imaging, we have new growing indications, probably summarized in this slide, because EUS is still an amazing diagnostic tool. I'm sure that if I ask 80% of the cases that we all do is not therapeutic, is still diagnostic. And we have a role, and I will encourage you to increase your indications and, of course, therapeutic. And I believe that this advanced imaging is leading to have more number of diagnostic and therapeutic indications. Future, artificial intelligence. I'm working together with Carlos Robles. I think Carlos Robles, you know very well. Everyone knows Carlos Robles from Guayaquil. He's probably the leading guy on all the investigation in AI, but also in EUS. And it's a very nice paper that I think Stefano maybe knows a little bit of the review. So just get the time to bring here. But we have data on artificial intelligence in pancreatic cancer. But probably for me, it's more important artificial intelligence for training, to optimize training. And I think this is one of the goals that may reduce the learning curve of EUS that we still believe is very high. Take-home messages.